I'm Donald Singer, Chair of Healthy Heart Charity, the Cardiovascular Research Trust. And today's session concerns international perspectives and what pharmacists can do in terms of cardiovascular prevention. I'm delighted we have as our organizer today, Inertia Soni, who's a trustee of the charity. She is a pharmacist working with NHS England and NHS Improvement.
Thank you very much, Donald. And I'm delighted that we are hosting this really important webinar today. As we know, cardiovascular disease is a leading cause of premature death globally, with nearly 18 million people dying each year from cardiovascular diseases. And that's, approximately 32% of all deaths worldwide. And there are significant opportunities to reduce the risk of people dying that have developed cardiovascular disease through CVD prevention. But of course, this requires innovative ways of working and, importantly, collaborative approaches between health and social care professionals, especially to support tasks like risk factor case finding, like hypertension, hypercholesterolemia, atrial fibrillation, engaging with communities and promoting healthy diet and lifestyles, and of course, optimizing medications that are vital for CVD prevention and management. And today, we spotlight the role of pharmacists that make an important contribution in this field. And it's with great pleasure that we've got three guest speakers on our panel today who will be shedding light on this topic from their respective countries. We're joined by Professor Ross Suzuki, who is joining us from Canada and is the professor and chair at the Department of Pharmacology at the University in Alberta and the director of the Epicor Center. We're also joined by Professor Martin Schulz, who is joining us from Germany. Amongst many of his hats, he is joining us in the capacity of the adjunct professor at the Institute of Pharmacy at Freie University in Berlin. And of course, Helen Williams, who's joining us from England and is the consultant pharmacist for cardiovascular disease and national specialty advisor for cardiovascular disease prevention at NHS England and Improvement, as well as UCL partners. We will be doing some polling today. So we will start off with the first poll now, followed by Professor Ross Suzuki, and then we'll have another poll followed by Dr. Martin Schulz, and then finally another poll followed by Helen Williams, and then we will take some questions from the audience. So please use the chat box to send through your questions. I'll just read out the question for those that can see it. What are the key ingredients to allow pharmacists to manage cardiovascular risk? A, prescriptive authority. B, the ability to order laboratory tests. C, a system of case finding. D, professional relationships with other stakeholders like physicians and medical societies. E, systems of fair remuneration for pharmacists. F, a change in pharmacists' mindset towards responsible patient care. And G, all of the above. We're landing with the majority of the answer, G, all of the above. Over to you, Ross.
Okay, well, thank you very much. Thank you for the honor of asking me. I'm very pleased to be here, and I hope that I can answer the questions in the poll. So I'm going to give you the Canadian perspective. Here are my disclosures. And this is what I will be covering in the next 15 minutes. I think the obvious question is why pharmacists in cardiovascular disease prevention. I'll just very briefly touch on that. I'll give you a very brief context of the scope of practice in Alberta, Canada, and the evidence for pharmacists prescribing and some next steps that we are taking. So why pharmacists? I think you all know this, but accessibility, I think, is really key. Primary care pharmacists are highly accessible where cardiovascular risk arises and is or isn't treated. Also, the opportunity, I think, is really important. Pharmacists see their patients up to 10 times more frequently than they see their physicians. So you can see, obviously, the opportunity therein. COVID-19 has definitely reduced in-person physician visits. Depending on where you look, around 70 or 80% reduction in in-person physician visits. So therein makes it that much more important. The one thing I really want to highlight is case finding, and that was brought up before, because usually when I get invited to speak at sessions like this, it's about the intervention. And obviously the intervention is important, but the intervention is completely useless if we can't find the people who need that service. And so I define case finding as proactive, the proactive systematic review of patients using their demographics and risk factors to increase the yield. And in particularly with pharmacists, we can use medications. For example, something like running a list of people on metformin to get a big list of people with diabetes, if that's where you wanted to focus. The fact of the matter is patients often don't seek care because they don't know that there's a problem. They don't know they have hypertension, or they don't know that their blood pressure isn't well controlled, or dyslipidemia, et cetera. Also, there are underserved populations that we know are at higher risk for cardiovascular disease. For example, those with chronic kidney disease and chronic inflammatory conditions, but nobody seems to want to own that group. And so that's another group. And I think rather uniquely, pharmacists can employ these proactive techniques. So to give you a bit of context, so Canada is a mishmash of provinces, and we have different laws in different provinces, which is incredibly inefficient. But where I'm based in Alberta, we have what we call a full scope of practice, which means pharmacists can administer injections, order and interpret laboratory tests. We can do various kinds of prescribing, but independent prescribing you can apply for, and that has been quite popular. And we can be paid for disease management, both acute and chronic. So let's jump into the evidence. I'm just going to go through very quickly. The reaction study was to look at independent pharmacists prescribing on systolic blood pressure reduction. So this was a randomized controlled trial in community pharmacies in Alberta. We enrolled 248 patients who had blood pressure above the target set by Hypertension Canada, that is greater than 140/90 or greater than 130/80 if they had diabetes. And pharmacists use case finding methods to find these patients. So we conducted a per patient randomization to intervention, which is pharmacist assessment of the blood pressure and cardiovascular risk, prescribing, laboratory testing, patient education, and follow-up. Basically, we said, here are the Hypertension Canada guidelines, please follow them. And they did. The control group, now, we weren't able to do nothing in the control group, so it wasn't really a placebo. Ethics wouldn't allow us to do that because we'd identified people with poorly controlled blood pressure. So it was whatever the pharmacist would normally do, and then they referred the patient to their physician with the blood pressures that they had taken, written educational materials, and that referral. In both cases, the patient's physician was notified because we don't do this in a vacuum, and the blood pressure results were shared. Here are the results. This is blood pressure reduction from time 0 to the end of 6 months in the two groups. The gray bars represent usual care, the control group, and the blue bars are the pharmacist prescribing arm. You can see the blood pressure systolic was reduced in both groups, actually, but reduced more when the pharmacist took over the prescribing, both with systolic blood pressure and diastolic blood pressure. So you can see minus a drop of 18.3 millimeters of mercury. People were 2.3 times more likely to achieve their target blood pressure in the pharmacist prescribing group. We also did an economic evaluation, just very simplistically, because I'm not an economist. We looked at the costs to roll out such a program, and then the benefits, which would be accrued later on in reductions of strokes, myocardial infarctions, and kidney failure. So, as you know, costs could be higher or lower. The outcomes could be worse or could be better. And of course, basing it on the reaction study, we calculated an individual cost savings of 6,364 Canadian dollars over 30 years, which doesn't sound that impressive, but if you applied it to half the Canadian population with uncontrolled hypertension, we calculate that you would see 540,000 fewer cardiovascular events, a million life years gained, and a cost savings of, you can see, £9 billion over that 30-year time horizon. That's after you account for paying pharmacists, the extra drug costs, and the training costs. The second study, I was asked after this, could you put the whole thing together? And so we have one regional health authority for the entire province. And so the head of cardiovascular medicine asked me, could you do this? And of course I said, yeah, we could do it. And so he wanted to put it all together to look at cardiovascular risk. So the objective was, again, a community pharmacy-based prescribing intervention in patients at high cardiovascular risk. So this was 723 patients at high risk for cardiovascular events, which we defined as those with diabetes, chronic kidney disease. Now that group had never been focused on before, but is at high cardiovascular risk. Those with established vascular disease and those with high Framingham risk, primary prevention, and at least one uncontrolled risk factor, which is virtually everybody. And they were randomized to the intervention or control. And the intervention itself was cardiovascular risk assessment, patient education, following the guidelines, prescribing, and follow-up for 3 months. The control was usual pharmacist and physician care, like the previous study. So the intervention itself involved the assessment of the patient, lab assessment, cardiovascular risk assessment, treatment, and follow-up for 3 months. We used this risk calculator, which we developed, which uses the UKPDS, Framingham, or the Smart Risk calculator, depending on the demographics. And this ended up being a very important part of the intervention because the pharmacists use this as a tool to teach patients about their risk, because we know that people don't understand risk very well. And so in this particular example, you can see this meter is in the red zone, which is obviously bad. But what's interesting is you can look at the contribution of that risk based on the formula used. And in this particular case, the purple part, you can see that most of that patient's risk is due to their smoking. So what you can do is you can go through this with the patient and see, here are the factors that you put in. If you click on smoking and say, well, what if you quit smoking today? You can see the risk go down in real time. And what if you brought that blood pressure of 153 down? So you can slide this down and again, see what impact it has on the risk. That ended up being a really important thing for the patients. So here's the primary outcome. This is estimated cardiovascular risk as calculated with that calculator at baseline and at the end of 3 months. And you can see the gray bar is usual care, not much of a change. And over the 3 months, you can see a 21% relative reduction or 5% absolute reduction in their risk of a cardiovascular event in 10 years. These are the other outcomes. You can see a pretty large reduction in systolic and diastolic blood pressure, reduction in LDL. In those patients who had diabetes, you can see a reduction in their A1C. Remember, this is only 3 months, and a 20% reduction in smoking as well. So we also asked patients what they thought about this. And to make a long story short, we had a third party who did this, and a patient, in fact, and they described 3 different themes: patient-pharmacist relationship, healthcare system, and patient reactions. And essentially what they said was they were very supportive of this full scope of practice. They were reassured that pharmacists weren't doing this on their own. They were sharing this information with the patient's physician. And they really like the accessibility and the relationships and the compassion of the pharmacists. That we got quotes like no one has ever explained this to me so well before. And so that was interesting and I think quite important. You know, the numbers are important, but I think this is also extremely important. So in terms of next steps, what we are doing is we need to implement this on a wider scale, obviously. So one of the things that we do, and this is now the 12th iteration of this, we are working with Hypertension Canada, and we do when Hypertension Canada does a set of guidelines, we do a set of guidelines that parallels it for pharmacists. So that's one thing. Hypertension Canada, this is our previous president, has been advocating for prescribing authorization for pharmacists, because in other provinces other than Alberta, that is still not allowed. And we've also developed a professional certification program in hypertension management specifically for pharmacists. And we're just winding up a randomized trial of this right now. So stay tuned. I hinted that there are other conditions that seem to fall through the cracks. And so this was just published in BMJ Open, where this was the REACH study in patients with inflammatory arthritis. So we took patients with psoriatic arthritis, rheumatoid arthritis, ankylosing spondylitis, and their cardiovascular risk gets ignored. And so in a similar sort of fashion, you can see there was a 21% relative risk reduction in those patients. This in a non-randomized trial, because of course we weren't allowed to do it as a randomized trial anymore. So I would like to summarize by saying, there's strong evidence, in terms of the pharmacist's care for cardiovascular disease prevention in the community. I think it's important because it is happening in the community and it's highly accessible. It includes those underserved groups, like I mentioned, chronic kidney disease and inflammatory conditions. But I think really case finding is key. And this is something that pharmacists can uniquely do. It uncovers those patients who need those interventions. I've only talked about the evidence that that we have contributed, and Professor Schultz and Ms. Williams will talk about some other evidence. But suffice it to say that there is really strong evidence for this. Wherever we've measured it, the healthcare costs are dominant in that they are lower with the intervention. And I think really importantly, this is strongly supported by patients, and that is, I think, one of the most important things. Patients like it.
Thank you very much, Ross. I'm just going to open up the second poll. Okay, you can see that. So the second poll question: in which areas do you expect the greatest impact of pharmacist interventions? A, we've already got some responses coming through: early detection of hypertension. B, blood pressure control of patients diagnosed with hypertension. C, control of HbA1c. D, control of LDL cholesterol. E, medication non-adherence. Or F, all of the above, A to E.
Anisha, do you think, just while people are finishing the poll, we might ask Ross whether he could comment on one of the questions in the chat here? And that was how you go about case finding in Alberta, how efficient that is, say, compared to nurses in practice or other ways people might have case finding going on.
Yeah, thank you. Yeah, in fact, I was just trying to type my response, so this is much easier. It depends on the condition that you are looking for, but it can be as simple as running lists of indicator medications. So I mentioned before, if you want to focus on those with diabetes, you can do a list of patients on metformin as one example, as a way to really narrow down that search. In the case of the inflammatory arthritis, we of course ran lists of biologics and typical medications that somebody with rheumatoid arthritis might be on to narrow down that search. So I think that proactive, because people don't know to ask for these things generally, you need to have a list and start asking, and that's the first step. And then the second step is to assess that patient. And in our studies, what we did is we actually asked them to call patients in and assess them, as opposed to if somebody shows up for a refill, you could do it then, but usually the timing isn't ideal for that. So that I think is really, really, really important, because what I always say is you could have the best therapeutic knowledge in the world and can prescribe anything, but it's useless if you can't find those patients who are poorly controlled. And so I really think that one of the things that we're focusing on is not so much the intervention. That's kind of common sense and it's guideline driven. It's the case finding. And I think that's something that pharmacists can do quite uniquely.
Thank you very much, Ross. I'm going to stop sharing and allow Martin to share his screen. But as you can see, Martin, the majority of responses are saying all of the options, although there is a 10% split on early detection or blood pressure management.
Thank you very much, and hello to everybody, and thank you for the honor to be here and to contribute with the role of pharmacists in cardiovascular disease prevention from a German perspective. Here are my potential conflicts of interest, a lot of them, and as you can see, and here's my outline. So what we want to do is we want to prevent this nice beating heart to end up with atherosclerotic cardiovascular disease. And this was about the question that here are the risk factors: high blood pressure, high LDL cholesterol, high blood glucose or HbA1c, and of course non-adherence to cardiovascular medication. And the answer is tricky. I think there's no right or wrong, but I think the early detection of hypertension, in fact, will have the greatest impact, because we can prevent people to develop end-stage renal disease, myocardial infarction, or stroke, or heart failure 20 years later in life, and with all the deleterious consequences. However, all of the above, all these risk factors are maybe under the control of pharmacists in primary care. As Ross said, I will just really briefly go into the overall evidence. The evidence is there for pharmacists in cardiovascular disease prevention. And I will share a little bit of our current negotiation. They are not finalized, but by law, there are 150 million euros on the table, which should be negotiated between the health insurance funds and us as the German Pharmacists Association. And they may include medication management or medication review or new medicine services, as you have in England. And of course, two areas are very, very important. One is diabetes, the risk for developing diabetes with blood glucose measuring and find risk. And one is, which I will go into more detail, is hypertension screening and blood pressure control. So the evidence is there. Here are only some examples where you can see what pharmacists can contribute in the areas of hypertension, diabetes, and dyslipidemia. Here are also evidence which we recently published in the evidence for pharmacist care in outpatient with heart failure. So this is also, there's evidence from randomized controlled trials. And this is the hypertension picture, and we have at least 39 randomized controlled trials for pharmacist care in hypertension and blood pressure control. This is the previous, or the meta-analysis of Valérie Sanchy from 2014. And you have seen, here's the point estimate of the mean difference in systolic blood pressure of minus 7.6 millimeter mercury. And you've seen the results of Ross study, minus 6.6. Then the famous Victor blood pressure control in black barbershops cluster randomized control trial with an enormous minus 22 reduction in systolic blood pressure in the greater area of Los Angeles. And there's a recent meta-analysis published in the British Journal of Clinical Pharmacology incorporating all these newer studies and showing roughly minus 9.3 reduction in systolic blood pressure. Well, the other issue is what I'm interested in basically is that medication adherence. And this is simply enough, but it is famous. This is Dr. Everett Koop, the former US Surgeon General, who once said drugs don't work in patients who don't take them. And the question is, so what? Does it matter? Yes, it doesn't matter. This is here the relative risk of all-cause mortality between good versus poor adherence to cardiovascular medicines. What you can see here, 23 studies, over 530,000 participants, and a minus 38% reduction in all-cause mortality for adherence to any cardiovascular medication. And above that, it is roughly estimated that 9% of all cardiovascular disease events in Europe are attributed to poor adherence to vascular medications alone. So this is an issue. And are there simple solutions like phone applications or text messages? This is a very recent Cochrane database systematic reviews on mobile phone-based interventions to improve adherence. What you can see here are 14 randomized controlled trials, including more than 25,000 patients with a minimum follow-up of 1 year, that there's low certainty evidence to increase that mobile phone delivered interventions will increase adherence to medication and in primary prevention of cardiovascular diseases. And there's only a modest benefit of studies showing that this will result in surrogate endpoints like reductions in LDL cholesterol, and nothing has been shown for blood pressure. So these are scalable, but fancy technology interventions have a lot of pitfalls and are far from being the one who's doing the job. So what we can do is, and what we tested in our Pharm-CHF study and in heart failure patients, acknowledging that you cannot cure persistently poor medication adherence. So this is a lifelong intervention. This is pretty clear from the evidence. What you can do is you can have regular contacts to your local pharmacy, because heart failure patients, I think Ross mentioned that also blood pressure, far more often see their primary care pharmacists than their primary care physicians. And you can add a dosing aid. And what you can see here, this is a proportion of adherent patients defined by a percentage of days covered, or at least 80%. And you can double the number of patients with PDC above 80. And the odds ratio is approximately 3 for all heart failure medications, especially effective for beta blockers, but also for ACE inhibitors. And what you can do is you can improve medication adherence if you use dispensing data. You can use dispensing data for case finding, but you can also use them for a refill reminder service, which we have studied in community pharmacy, and this is very important. So to summarize that, this is our 2 systematic reviews. Patients receiving pharmacist-led interventions are associated with a statistically significant reduction in their systolic blood pressure and HbA1c and LDL cholesterol. You have also a positive impact on medication adherence, and also not only in Alberta, but overall, these pharmacy-based interventions are cost-effective for cardiovascular disease prevention. So let's do it. But how can we do that? The one is case finding. The other one is how can we sustainably implement services? This is very crucial. What we have done is we have identified an unmet medical need in primary care. Go to your stakeholders, for example, here the German Diabetes Society, and we cooperated with them, develop joint practice guidelines, as Ross mentioned, for coronary artery disease, for hypertension, for heart failure, develop a quality assured standardized interventions, show the evidence, of course, not only efficacy, but also effectiveness, go into negotiations, what we're doing now, and document the effectiveness and provide incentives. And this, and we should discuss that probably at the end of this session, this should not be limited to appropriate reimbursement. This is a necessary prerequisite, but this is not the ultimate solutions. Yes, and this is what we did also together with Ross and the German, the working group Hypertension of the German Cardiac Society. We developed and implemented blood pressure screening and referral guidelines for German community pharmacists. And this has been published last year in the Journal of Clinical Hypertension. These are these working sheets which we provide either for subjects without known hypertension and for patients with known hypertension. And we are now testing the referral criteria with regard to, can we detect early on patients with hypertension or risk for hypertension, and make an intervention very, very early in the patient career. These are the current guidelines, traffic light referral guidelines, which we're testing for screening for hypertension for patients with hypertension. And these are currently in a new study to test how many patients we can diagnose very early on. Well, this is all what I would like to contribute in this 50 minutes, and I thank you for listening. I'm looking forward for this discussion.
Thank you very much, Martin. Thank you. And we will take our final Mentimeter polling question. There is one question that has come through, which Ross did answer in the chat box, but maybe you would also like to contribute to, is could unmet health needs be met by comprehensive medication reviews by a pharmacist? And what do we know about patients' reasons for not adhering to their medicines?
Wow, well, the second question is really difficult. There are many, many reasons. There's intentional non-adherence and non-intentional non-adherence. So we can tackle the non-intentional or unintentional non-adherence, of course, with reminders and SMS functions and refill reminders and good apps, which are interactive. However, with regard to the intentional non-adherence, it is very, very difficult. These are many, many questions of not knowing that there is a problem, ignoring that there is a problem, ignoring that you don't want to be sick and you don't want to be vulnerable. So there's beliefs in medicines which are quite unique sometimes, and you can figure that out with specific questionnaires. At the end of the day, it is an individual task, and this is also one of the, I think, advantages. If you take time to speak with the patient, for example, if you do a medication review and you have 30 minutes with the patient, then you can address these questions and find out the individual reasons, whether these are side effects or which are beliefs or whatever, or it's a burden of medication, and you can simplify the regimen. So this is, these are some of the many, many reasons. It's difficult, and be remembered, you can't cure that persistently. This is a lifelong condition.
Thank you very much, Martin. So this is our final polling question. What is the most, that should not be post, that should be, what is the most important risk factor for cardiovascular disease? A, high blood pressure. B, tobacco use and smoking. C, obesity. D, stress. E, alcohol. Yes, please. Thank you very much.
Right. So most of you said high blood pressure there, and at a global level, high blood pressure is the leading risk factor. In the developing world, the last time it was looked at, it was actually tobacco use. But obesity is quickly catching up as well. So I think, you can't focus on one sole risk factor. And clearly, when we identify a risk factor, we need to look at global risk and particularly address smoking and obesity alongside hypertension to really drive down cardiovascular risk. So I'm going to talk about the UK perspective on the role of pharmacists in CVD prevention, and not talk so much about the evidence base, which we've already heard quite a lot about. More think about how we're embedding it into routine practice. And it is entitled the UK perspective, but I work in England, and the NHS across the UK operates in sort of three segments: England, Scotland and Wales. So it may well reflect more of an English view than a full UK view. So we have very significant ambitions for England around cardiovascular disease prevention, AF, high blood pressure and high cholesterol in terms of both detection and treatment. They won't seem quite so ambitious to Ross, because I think they've already delivered these hypertension ambitions in Canada, but we've still got quite a lot of work to do in high blood pressure, although we are doing very well at the moment, or at least pre-COVID, we're doing very, very well with atrial fibrillation. So we've already heard a little bit about why we should focus on pharmacy. From a UK perspective, There is a significant challenge on the front line, even pre-COVID. GP numbers were falling, healthcare professionals were leaving the NHS, and there'd been funding cuts, and pharmacy was the only healthcare profession that had a predicted oversupply by 2025. So we're thinking, 10, 15 years ago, we were looking at this and what could we do with that oversupply of pharmacists? Because medics, doctors and nurses are capped in the number of people who train year on year, but there wasn't a cap on pharmacy training places, and there were increasing numbers of pharmacy schools and pharmacists in training. And we'd seen the roles, the extended role of pharmacists really being embedded in acute care. So it was very common in the hospital, it is very common in the hospital setting to have pharmacists on ward rounds, leading in outpatient clinics and really supporting the wider clinical team. In the acute care setting, we need to think about how we could take that out into the primary care setting. And we also knew, of course, that if we did deliver better medicines optimization, we could improve outcomes, reduce demand, particularly in acute care, and save money overall. We've heard a little about why we should use community pharmacy. We've got some interesting statistics about community pharmacy in the UK, that most adults visit them at least once a year. Many adults repeatedly visit. The average user 16 visits to a community pharmacy per year, and very accessible on the high street. Most patients can access a pharmacy by walking or by public transport. They tend to have longer opening hours than general practice, and extending into evenings and weekends. And we usually say they don't need appointments, but actually the more of this sort of chronic disease management work pharmacists get involved in, the greater the chance that we might need to actually implement appointment systems to manage that. So we're using community pharmacists in all sorts of ways, not necessarily fully consistently across NHS England, but pharmacists are involved in delivering NHS health checks, which is a full cardiovascular risk assessment. So looking at the detection of high risk conditions like hypertension, diabetes and high cardiovascular risk, and the use of new technologies for AF case finding, like the blood pressure machines that have the atrial fibrillation detection element to them, or this little device that you can hopefully see in the right hand corner, known as a live call, which fits on the back of a smartphone and will do a single lead ECG chase. And we have many interventions that are embedded within the pharmacy contract. So healthy living pharmacies will offer smoking cessation advice, weight management programs, general lifestyle advice, and signposting people to local services. There are pharmacist prescribers managing long-term conditions within community pharmacy, so hypertension, anticoagulation in AF. Some of the contracts are held by community pharmacy now. Opportunities in disease monitoring. Again, this isn't so well embedded, but it is a huge opportunity going forward. So as we've already heard, patients will visit their pharmacy way more and have contact with their pharmacist much more than they will their primary care physician. So why not check their blood pressure every time they pick up their blood pressure meds? Why not check their HbA1c? What about doing INRs for patients on monitoring and doing the dose adjustments? And then obviously we've got some adherence support programs like the new medicine service and medicines use reviews, although really it's moving much more towards new medicines service. So great opportunities in community pharmacy. The biggest challenge, of course, is making this consistently offered across the system, so all patients can access it, so that we don't develop or enhance existing health inequalities around access. And we're hoping to see many of these become part of the core contract for our community pharmacies, rather than relying on local commission arrangements. Just to comment on the NMS, the new medicine service, many of the CVD prevention drugs are incorporated into the new medicine service now, and there is evidence that this has improved patient adherence by around 10% across the board, not specifically cardiovascular, but great data that early intensive support for patients can improve their long-term adherence to their medicines. But I don't know if we're unique in the UK, but I don't think it is unique, but we certainly have also invested in pharmacists within what we would call the general practice workforce. So this is your primary care physician, your doctor's surgery, Traditionally, we've had doctors and nurses, and now we're seeing pharmacists as part of the solution to some of the problems that we've got within general practice, particularly in terms of insufficient workforce. If we can put pharmacists in with very specific skills, particularly around long-term conditions management, it will free up the GPs to work in other areas. So we have initially had pharmacists embedded within individual GP practices. We're now looking at pharmacist teams working across a network of GP practices so we can develop some sort of infrastructure and progression within the roles. And some supervision of pharmacists work within these networks, but obviously clinical patient-facing roles around long-term condition management, medicines optimization, opportunities to do medication review, but also opportunities to support the wider GP workforce to do their job when they see these patients for cardiovascular risk assessment and management better. Pharmacists love a good algorithm and a good protocol, and will make sure that's embedded across the system. GPs, nurses, pharmacists working to those same standards. We have evidence around pharmacist prescribers. Pharmacists have been able to be independent prescribers since 2007, and the data on the ability of pharmacists and nurses has been looked at in terms of the capabilities, and this Cochrane review concluded we were as effective as GPs at prescribing, which is an interesting outcome. I might suggest we may be even better because we're so obsessed with optimal drug use. And we've already seen this study. This is just one study that shows the impact of pharmacists in general practice on the management, in this particular circumstance, looking at systolic in the top graph and diastolic blood pressure, having pharmacist intervention in general practice to improve blood pressure control. And this is the one of the UK publications off the back of it. And part of the importance, I think, is the messaging around pharmacists complementing the rest of the team and supporting the rest of the team in holistic patient care, making the use of the different skills of the wider workforce going forward. We have examples of individuals, pharmacists and nurses working together to improve blood pressure management. And I just thought you might be interested to hear a bit about the work that I've done. So I was initially asked to come out to primary care from the hospital setting to help with blood pressure control. And on a 9-month secondment, I found myself still doing it 3 years later, and had decided that there's no point in me trying to do all this work. I needed to train other pharmacists to do the work in order to make it more sustainable. So we started doing pharmacist-led hypertension clinics, focusing on the patients the practices were struggling with. So we only wanted the uncontrolled hypertensives that the practices couldn't manage. And you can see that within 6 months, we got 56% of them to the clinical target, 140/90, and nearly 80% to the payment, the QOF target at the time. And that resulted in a pharmacist-led community hypertension service, which is still delivered in South London. But looking at the data, we had a massive problem. A few pharmacist-led clinics half a day a week weren't going to resolve the fact that across just one of our CCGs, we had one of our boroughs, we had 8,000 uncontrolled hypertensives at a national level, over 1.6 million people with blood pressure above 150/90. And 3.4 million with blood pressures above 140/90. So we had to come up with something that was a bit cleverer than just trying to put more pharmacists in. And what we came up with was what we called a virtual clinic. And this actually was an efficient way of getting pharmacist support into general practice. So the practice would identify a cohort of poorly controlled patients. The pharmacist would go in and do what we call a virtual clinic. It was essentially a multidisciplinary team meeting and discuss how the management of those patients could be optimized. And then the practice went away and implemented those recommendations. So 1.5 hours of a specialist pharmacist time could impact on the care of 20, 30, 40 patients, which clearly you couldn't do face-to-face with the patients yourself in that same period of time. What we saw in that clinic was we went into 45 practices to do these virtual clinics. We got data on initially 1,982 patients, of which we had follow-up of 1,500. And the average systolic blood pressure drop we got across those patients who had a raised systolic at the point of the enrollment in the project was a 25mm drop in mean systolic blood pressure. And we know that that translates into a significant reduction in cardiovascular events, CHD and stroke. So a very efficient way to take a very small amount of specialist pharmacist time to influence the care of large numbers of patients over a small amount of time. We did the same thing with AF, looking at on patients with AF who were not anticoagulated. And we did this across 2 boroughs. The blue line is the first borough, went up in the first year that we did it, and then Southwark, where we got it all perfectly correct. In the second year, you can see we had a quite a significant impact, but what really matters is that reduced the stroke rates year on year. In fact, I think I've got 5 years data now of reducing stroke rates as a result of the anticoagulation intervention that we made, and this has now been taken up at a national level across 23 what we call CCGs, health areas. Doesn't translate well into international parlance, but that's now being evaluated to see the impact. And then obviously from my perspective, really important that as pharmacists we're involved at a leadership level, because the only way we can influence service delivery is getting involved in identifying the unmet need and looking at the levers and incentives we can embed within contracts to make this happen at a national level consistently. So we're looking to get blood pressure checks into community pharmacy at a national level in every pharmacy as part of their contractual framework. We need to look at how we implement the GP contracts to improve blood pressure control. How do we roll out these NHS health checks and make sure that we're really reaching the communities, the unmet need, the communities, not the worried well, the communities that aren't necessarily engaged? How do we equip the pharmacy workforce to deliver this? And how do we demonstrate our impact on outcomes? So mortality and morbidity, really important, but also the resources the NHS is investing, the efficiency, the workforce impact and the pounds that we might ultimately save. So lots of emerging roles across the wealth of pharmacy roles in the UK, in community pharmacy, around detection, prevention, lifestyle and behavioural change, and also adherence and persistence with medicines, moving into prescribing and monitoring of the drug therapy. We've got practice-based pharmacists doing routine meds reviews, medicines optimization, quality and safety, prescribing audits, adherence and running specialist CHD, hypertension, diabetes clinics. And then we've got the sort of system leadership piece around medicines optimization, strategy commissioning, wider scale audit, medicines optimization programs and utilising those contractual levers and incentives. So thank you for your attention. I will pass back to Anisha, I think.
Thank you very much, Helen. Really fantastic presentations and to hear the perspectives from yourself, Martin, and Ross this evening. There's been quite a bit of conversation in the chat box, so please, for those listening in, please continue to put your questions in the chat box. If you want all the panel to contribute to it, do state, otherwise do field them. But one question or one theme that's coming through is around traditionally pharmacists have worked in the space of medicines, but in all of the presentations we've heard about the role of pharmacists in case finding, be it incidental or be it active. And I suppose, Helen, if you'd like to answer this, followed by Ross and Martin, if you wish to add, how much should we be steering pharmacists into health services that are not specifically relating to medicines use and optimization? I mean, Helen, you already said pharmacists have to complement the team. So how do we do that so it's systematic and does not shift the workload, as it were, to our other professional family groups?
So I think from a detection point of view, there is great opportunity with community pharmacy because they reach a different cohort of patients than GPs. There's always a cohort that are family physicians can never reach, and the community pharmacy on the high street has that great opportunity, and also younger patients. So many young men in particular don't have any need to go to their GP for many years, but have underlying hypertension that's not been picked up. So they might bowl up their pharmacy for a bit of ibuprofen because they sprained their knee playing football, and it's those sort of opportunistic opportunities that give pharmacy that, you know, a great chance to find these patients when they wouldn't be routinely found by the general practice. In the surgery setting, general practice pharmacists, I don't see that as being their main role. You know, there's healthcare assistants who are trained to take blood pressures, and they can do that. You know, patients take them themselves in the waiting room. So I think it depends on where you offer, what your unique selling point is, you know, your USP around the detection piece, and where you're going to use where your skills are best placed, depending on the team that you're working within.
Thank you, Helen. Martin or Ross, did you have anything you wanted to add to that point?
I'd just like to say that I completely agree, Helen. There is a segment of the population that don't see their physician for whatever reason, but they may very well go to a pharmacy. So I think those kind of opportunistic screenings are quite important. And you know, I think what has to change for pharmacy practice is pharmacists are used to receiving a prescription and then you fill the prescription. So somebody comes and has a prescription for metformin, you would fulfill that request and that's it, right? But I think that the change that needs to happen is that is a signal. So that's a signal that the patient has type 2 diabetes, and it's a signal, therefore, you should be thinking, oh, they haven't asked me about their blood pressure, but they probably don't know to ask for that. So that should trigger a pharmacist to say, what about your blood pressure? What about your feet? What about your lipids? You know, all these things that patients can't feel and don't know to ask. And I think the problem with pharmacy practice is we tend to sit back and say, oh yeah, I know all about all this, you just ask me. And that doesn't work, right? And that's why I'm really big on the proactiveness of finding cases and looking for these things that are not detected.
Well, I fully agree, and would like to add the issue of self-medication in OTC use. So pharmacists are get used that people come in and say, I want to have a bottle of this and that, and this is iron salts, or this is Grategos, or these are diet supplements, or whatever. And you don't have to wait for ankle edema or for dyspnea to make an early suspicion of heart failure. So you can use these situations where people come in and ask for a supplement or for an OTC drug, and you may question their symptoms. So you can use this opportunity to make a conversation with potential patients on their underlying causes with regard to, for example, heart failure.
If I could just jump back in again, that's really important. It's the opportunities. And in the chat, people were talking about medication reviews. And you know, the medication review in itself, yeah, it's okay. But it's that opportunity that it presents, I think, because patients are coming in for an assessment. And so you don't just assess the drugs that the patient's on. You assess what about the drugs the patient's not on, that should be on, maybe. And so it's that opportunity, turning those things into opportunities, not just evaluating the drug profile the way it is.
Thank you very much. I mean, we can't have this presentation without mentioning COVID-19. So a question to all of you really is, how has COVID-19 affected CVD prevention, detection or intervention, and more specifically pharmacy practice in achieving deliverables in those spaces, and you know, preferably in the countries that you're representing? If we start off with Helen.
Yeah, so COVID has had a huge impact on CVD prevention, both in terms of detection and in terms of management. So we know that there's been 50% fewer new hypertensive patients diagnosed in the past year. We have some early evidence that there's been at least a 20 percentage point drop in the control of blood pressure because people haven't been monitored and therefore haven't had the same number of interventions they normally would. Nearly 500,000 fewer CVD prescriptions. So it's had an impact, and at the moment we need to think about recovery. A lot of the work, or some of the work, is shifted to pharmacy, particularly around monitoring. Can't get to my GP, can the pharmacy do the blood pressure, which is a bit of an opportunity, but you know, pharmacy itself has been under a lot of pressure, just dealing with COVID and COVID vaccinations. So all of us across the whole health system, community pharmacy, practice pharmacists, hospital pharmacists need to start thinking about, well, what can we do to recover this situation? Loads of blood pressures are taken every day in hospital, but I'm not sure they're always communicated effectively to the GP, because even if they're normal, that's useful information for the GP. So they know they don't need to prioritize that patient versus the ones they haven't even got a reading on. So I think, we really need to tie up our pathways better. We need to be making every contact with patients count where we are seeing them face to face. At a national level, we're obviously also in the UK, well, in England, I should say, rolling out blood pressure at home programs, so supplying patients with their own monitors so that they can feed their results into the GP, and there's opportunities there for remote monitoring. But we really need to focus on this recovery, because we're building up a potential pandemic of cardiovascular events over the next few years, because we've allowed this to happen, because naturally we've been focused on other things.
I'm very afraid of what is going to happen. We don't have any data on that. What we know is that the number of visits to general practitioners has dropped by 50 to 80%, and hypertension is number one reason to visit. So you've got to think that is going to reduce control. And I know for hypertension, our Research and Evaluation Committee for Hypertension Canada just published in 2020 the data on blood pressure control. And we always had the best, Helen, you mentioned it, we always had the best blood pressure control in the world. And we were very smug about that, by the way. But we're kind of looking down now because it is actually getting worse. And in fact, the group that is most disadvantaged in terms of blood pressure control is that of the blood pressure control in mature women, and it's fallen actually below, it's 48%, and that was pre-pandemic. So what has happened with the pandemic? I'm sure it's much worse, and so that is really, really scary, but we don't have numbers on it yet.
Yeah, well, let me add only that also pharmacists are complaining of different work they have, and they're fully overloaded with other tasks of distributing vaccines and vaccinations and masks and testing. And of course, also they were scared at the very beginning to have close patient contacts, and patients were scared to have close contacts with healthcare professionals, not only GPs, but also pharmacists sitting in a small room, measuring blood pressure 3 times. It may take 15 minutes and so on. So these are new challenges, and I'm really keen to see now how we can go into our study, which is now with the ethics committee at this moment, and whether we can community pharmacies convince to invite patients with potentially underdiagnosed hypertension, and whether they are successful in recruiting enough patients for the study.
Yeah, certainly challenges, but also opportunity, as Helen said, opportunity.
Yeah, agree.
Pulling together some points from the chat, and as Anisha said, lots of important information coming through there from our speakers and our audience. The speakers have all said that the better you control risk factors, the better the long-term benefit, saying the obvious, but that's key. So thinking about, you get some very clear examples from Germany and from UK and Canada on blood pressure control. And Helen, you show that you can get from, say, 4 out of 7 control to 4 out of 5 control, really big impact. So that the question, I guess, for Canada and Germany is, you've shown relative reduction, I think, but to what extent are you able to get the sort of control you'd like in terms of the target factors with your interventions? And I think for all 3 speakers, how sustained are these benefits? Once you've got them down, are you able with pharmacy involvement to get sustained improvements? Perhaps you first of all, Ross.
Yeah, those are really important points. We don't have any long-term data on whether it's sustained or not. I suspect that it is not sustained. We did in one of our studies, which I didn't show, which was improving hemoglobin A1C control in patients with type 2 diabetes. And when we looked 1 year later, 18 months after the start of the intervention, but the intervention was only 6 months, you'd lost half the benefit. Now, some of that might be disease progression, but not that quickly. Yeah, we need to explore systems to sustain this.
Well, unfortunately, we do not have also these long-term data available. We only see that the percentage of uncontrolled blood pressure is high in Germany, and the hypertension diagnosis prevalence is increasing, obviously over the years. We don't know what is happening in the last 2 or 3 years, and COVID is now a completely new situation. I'm also not. I have the same impression like Ross, that it will be very, very difficult to get these results sustainably implemented. And it's not only blood pressure control. It's of course, you're not dying by high blood pressure. Yeah, you're dying by stroke or by a myocardial infarction or by heart failure eventually. So this is really what we need, these long-term outcome data with heart failure hospitalizations, stroke, and myocardial infarction. This would be very nice to have these data. So we probably need a good register, I don't know, an international.
And Helen, within your UK initiatives, the targeted virtual clinics, are you getting any long-term data coming in for sustained effects?
I suspect that this might depend on the area we're talking about, because the AF work, we've got 5 or 6 years of data now showing there's been no drop off. In fact, there's been a consistent increase in anticoag since the project at those CCGs that we looked at. But that's sort of once you've changed the behaviour of the practitioner to offer anticoag, it was mainly just patients weren't being offered anticoag because they were too old, too frail, they might bleed. So it was dispelling those myths. Once you've dispelled the myths, hopefully they don't reappear. Whereas hypertension is a very different kettle of fish, as we say in the UK. It's a marathon, not a sprint. There are so many things that affect patients and clinicians around. The things that really we saw was clinical inertia. So while you've got a strong focus on it, everyone's excited about it and really trying hard, and then over time you can't keep a financial incentive around it all the time at the same sort of levels. You have to work to embed it, and as that incentive goes, often the interest goes clinically to really focus on that, because there's so many other things and priorities that could be focused on. And then the piece about patient adherence. Over time, a patient that you were treating today in 2 or 3 years' time may well be non-adherent, and all of those messages need to be repeated and revisited. So I think it's always going to be an ongoing intervention, not a one-off that we're going to have to work on, and that's why it needs to be offered consistently across all community pharmacies if they're going to support adherence. GP practice pharmacists doing systematic reviews of uncontrolled patients and putting them back in and working on the optimization, not just of medicines but lifestyle. It's never going to be a sort of magic bullet intervention, I don't think, for hypertension.
Thank you very much. I suppose we probably look to wrap up our webinar today. It's been a fantastic webinar to see the perspectives from Canada, Germany and the UK, and really to see more or less we have similar challenges despite variable achievements on goals such as hypertension. The challenges around incentivizing, adherence, holistic management, working with the NDT. But we have our opportunities as pharmacists, and certainly our role has progressed across those 3 countries. And the evidence is clear, as all the speakers have shown. And we, most importantly, are supported very well by patients. And our USP our distribution and health systems in all the countries that we've heard from today. Thank you very much to the delegates for joining us today. Please do follow us on Twitter, CV Research. We've also got our own website, healthyheartcharity.com, and you can keep up to date with other webinars that we have. And thank you so much to our speakers, Dr. Ross Tsuyuki, Martin Schultz, and Helen Williams. Thank you so much for your time and sharing your expertise.
As two final notes, I'd like firstly to thank Anisha Soni for organising this excellent webinar. And finally, our Healthy Heart charity organises an annual World Healthy Life event. This is taking place with several online sessions during the week of the 1st of November to include stroke prevention, active transport, exercise and other ways to reduce and prevent serious cardiovascular diseases. You can find out how to suggest an event for the week or to attend one of the events by going to the website worldhealthylife.org.